Good morning, everyone. Let me briefly talk about my PhD thesis, which is about investigating minimally invasive neurosurgical interventions for patients with drug-resistant epilepsy. But before we are getting in the scientific and methodology part, I would like to introduce myself. My name is Arashk Zabihi. I'm a resident doctor at the Department of Neurosurgery at Hungarian Army Medical Center. And my aim is to improve the epileptic patient's quality of life while investigating novel, minimally invasive neurosurgical therapeutic interventions. About my specific goal, currently we have two projects. Both of them are kind of the same. We are investigating the same minimally invasive neurosurgical interventions in two different diseases. One of them is called mesial temporal lobe epilepsy, while the other one, this is the hypothalamic hamartoma. Well, the first one, investigating minimally invasive neurosurgical interventions in temporal lobe epilepsy. Let's talk about the background. What is epilepsy? It is worldwide, it's affected about 15 million people, out of which approximately 30 million people are having mesial temporal lobe epilepsy, which is a subgroup of epilepsy. Approximately 65% could be treated with anti-epileptic drugs, so become seizure-free, while 35% are drug-resistant. We are interested in this drug-resistant population of the patients, because approximately 15% could be treated surgically, and also or decreasing the rate of the seizure or becoming completely seizure-free. The aim is to investigate whether this MR-guided laser interstitial therapy provides a better postoperative rate compared to the stereo-EEG-guided thermocoagulation in patients with drug-resistant mesial temporal lobe epilepsy. Okay, what is the question? The question is the same. Does the MR-guided stereotactic laser therapy provide better outcome, surgical outcome, compared to the stereo-EEG-guided therapy? The population is drug-resistant mesial temporal lobe epilepsy. The intervention is the MR-guided therapy, while the comparator is the stereo-EEG-guided thermocoagulation. The outcome is called, we are interested in angle classification, which is the rate of seizure measured postoperatively. And there is a novel classification called ILAE, which is kind of the same, but the new articles are using mainly the ILAE. The clinical implication, what is the clinical implication? The reduction of seizure rate, and if it's possible to achieve the angle 1, so a seizure-free life. And also the shorter hospital stay, because with the stereo-EEG intervention, we need time to detect the epileptic focus, while with the MRI intervention, we see the area, where the focal seizure starts. Okay, the hypothesis is that the MRI-guided therapy provides better outcome than the stereo-EEG-guided therapy. We conducted a systematic search in 4 databases with the mentioned search keys, and we found more than 2,000 articles. By selection, we ended up with 17 eligible full texts, and the data extraction right now is in progress. My second project is also a meta-analysis. I'm comparing the MRI-guided laser therapy and also the stereo-EEG-guided therapy in patients with hypothalamic hamartoma. What is the background? Hypothalamic hamartoma is a non-progressive congenital lesion It is occurring approximately 1 in 100,000 children, and its main symptoms are called gelastic epilepsy, which is a sudden burst of laughing, and many times, approximately 75% of patients have other types of intractable seizure, and this is why we are interested in these minimally invasive interventions, to see if the other types of the intractable seizure could be treated with it. If not, the article wrote about the cognitive and behavioral disorders and other mental diseases, and also the mortality is much more higher. So our aim is the same as in the previous meta-analysis, to investigate whether this MRI, the novel therapy, provides a better postoperative rate of freedom from seizure compared to the stereo-EEG-guided thermocoagulation in patients with hypothalamic hamartoma. What is the question? Is the MRI therapy better than the SEEG therapy? But here the patients are patients diagnosed with hypothalamic hamartoma. The interventions is the MRI-guided laser interstitial therapy, while the comparator is the stereo-EEG-guided radiofrequency thermocoagulation. And we are also interested in angle classification and ELIAE, which was mentioned previously. The clinical implication is quite the same. The most important thing would be to achieve a completely free seizure freedom. And the hypothesis, it is again the same, the MRI one. We hypothesize that the MRI intervention provides a better outcome than the SEEG intervention. In the systematic search, we checked in 4 databases, and the search keys mentioned here. The flowchart of selection, there were exactly 492 articles, and 31 are eligible for full text right now, but this one is in process because this project was started just 1 week ago, so it's quite a new one. But both projects, I'm planning to submit the articles next summer, so in approximately half year. And I would like to thank you for your attention, and I would like to leave you with one of my favorite quotes, which says that you cannot ever reach perfection, but you can believe in an asymptote toward which you are ceaselessly striving. Thank you very much.
Which method do we use actually today for surgeries?
We are using this SEEG RF-TC method because it's much cheaper. The MRI one is available in America right now.
So you are starting with the other one too?
Yes, the MRI one was accepted by the FDA just a couple of years ago. Yep. So it's a new one, and we don't have a huge databases with patient population.
Okay. So this may actually go to a clinical trial, I mean, on your side. I understand that right now, yes, actually, you deal with in silico, I would say. Mm-hmm. But that is always good to go to the clinic stand, and then yes, when you start to use this, actually, you may do a registry or clinical trial or whatever. Mm-hmm. And we
would like to do, yes. I talked to the director of the neurosurgical clinic, OMI in Hungarian, and he proposed to make a registry, a national epilepsy registry. That would be my 3rd project, but it's a new project, so I couldn't even mention right now what would be that about.
I mean, this is great because this is translational medicine anyway, so finally, I mean, it should reach healthcare.
Thank you.
How could you define the bad and good clinical outcome after the procedure?
Yes, the outcome is called angle classification. We are measuring the number of seizures 1 year after postoperatively. And there are four classification, 4 types. And the first, angle 1, is when we get a completely seizure-free patient. And of course, the fourth, angle 4, is no change.
Thank you very much.
Since Arash is my student, it's not very ethical to ask complicated questions. I have only one question, like, do you know how can you measure the seizure freedom? Because sometimes it's, self-reported, sometimes it's not. Do you have any idea how to perform this experiment? I mean, not in this specific topic, because that's going to be a meta-analysis, but if it would be like a clinical trial, do you have any idea how to measure who's seizure-free, who's not?
I think the self-reported method would be the better case and the option, because we cannot have a patient for 1 year near us, and especially not a couple of hundreds of patients. So even if it can be biased, this is the best option, the self-reporting one.
Okay, thank you very much for your presentation.
Thank you for the opportunity.